I think that Melcher was a very fantastic researcher, and I think the regeneration started with these experiments. Based on the Melcher experiment in the fall 1977, he published papers describing that four kinds of cells can migrate over exposed surface after the scaling replane, after periodontal therapy. The first one, and the most speedy, was the epithelium that migrate apically, running, and colonizing the exposed surface. In that case, we can have only a long junction epithelium to mediate the gingiva and the tooth. Sometimes the gingiva connective tissue can reach the exposed surface. In this case, sometimes he noted a kind of superficial resorption of the root, and that was not a very good situation. If the bone cells are close to the exposed surface, ankylosis occurred, and ankylosis provides a complete distortion of the roots. So only periodontal ligaments the periodontal ligaments coming from the space of the space from the bone and from the vessel of the periodontal ligament can colonize the coagulum and initiate the regeneration with the formation of the first fibrils, formation of the new attachment, and in some cases, formation of new bone. Therefore, the placement of the membrane were aimed just to avoid the run of the epithelial cells and allowing for the colonization of the coagulum by the periodontal ligament cells. I think that Melcher was a very fantastic researcher, and I think the regeneration started with these experiments. And after Melcher, Niemann and Linde School continued this experiment showing all this material. I am very surprised treating my first patient along with Sandro Cortellini. He was a young student, 18 years old, and he had a great angular bone defects, 15 bone loss in the frontal tooth, mobility. It was due to the elastic forces that were posed from the orthodontist to close the diastema. We removed open the flap, we removed the elastic, we cleaned the defect, and we put a millipore filter ad modum on Niemann. And we closed the flap, and after 3 months, we removed the millipore filter, and we had a surprise, a fantastic bone regeneration all around the tooth. And this was very interesting. It was published in the Journal of Periodontology in 1985. After that, I continued to follow this person. And after 30 years, he has a fantastic and perfect situation of this tooth by 0, complete regeneration of the bone close to the cemented enamel junction, and a good aesthetic result. If you think that at that time this tooth should be removed easily from the dentist, and the guided tissue injection provide us the maintenance of the tooth for a long period of time. We start to understand that the positioning of the barrier was very important to achieve good clinical results. In the first time, we put these barriers at level of the bone crest, just to filling the infrabony defects. After that, using the papilla preservation technique, a new kind of suturing, we try to create space with the titanium supported membrane coronary to the bone crest, just to try to regenerate also the horizontal bone loss over the crest of the bone. And the titanium reinforced membrane were very helpful for that, and I think they are still the best devices that we can use if we want to achieve a coronal regeneration of the bone. One of the problems during the first treatment was the exposure of the membrane after 1-2 weeks of the procedure. And usually because the top of the papilla, of the two papilla, opened, leaving the membrane exposed, and the infection was one of the main causes of the unsuccess of the treatment. Therefore, Sandro designed this new technique, this new flap, the papilla preservation technique, where the papilla was removed along with the palatal or lingual tissue, and the approach was very clean. And after that, when we repositioned the flap in its original position, two different kinds of suture were performed. The first one at the basis of the papilla, just to fix the soft tissue in the buccal and the lingual aspect or the palatal aspect, to avoid any strain on the top of the papilla. And after that, when the tissue was completely accomplished, we used to suture also the top of both of the papilla. After that, the surgery, according to the principle of the general surgery, changed much and changed a lot. And now, according to the minimal invasive treatment, we start to approach the lesion in a less invasive treatment. We can treat isolated single defects or closed defects, removing only, opening flap only in the vestibular part of the side, just leaving the other side that is represented by the soft tissue of the lingual palatal gingiva, removing with great attention all the cementum and the infected cementum from the root surface, and maintaining the soft tissue as a wall without opening the flap. And in this way, we can save a great amount of vascularization that provides us a better regeneration. Inside of the defect, we can put some bone substitute. Sometimes we can use amelogenin, sometimes use nothing. And the most important thing is to stabilize the flap and to stabilize the coagulum. Only in this way we can reach predictable result of the treatment of angular bone defects. Therefore, minimal invasive treatment, I think, is the key. It is the key for the new treatment of these specific defects of strategic teeth. The principle of guided tissue regeneration was developed also in guided bone regeneration, and there are many patents and many studies demonstrating the possibility to rebuild coronally the bone. And as Tinti, Parma Benfenati, other famous researchers provide us. And I think today the most important thing is the bone regeneration before placing implants can occur only if this procedure is occurred only if with the complete closure of the wound over the membrane, over the bone graft, because in the same way, if the soft tissue are opened, there is possibility to the failure of the procedure. In the other situation, if you are treating a periimplantitis, we can use also guided bone regeneration. And there are two different levels of interest. The first one, if there is only an angular bone defect around the implant, we have to improve the quality of the surface using different materials. And after that, we can put bone and membranes and cover everything with soft tissue. In some situation, maintaining the implants and the tooth over it. But if we have a perimplantitis just showing a complete horizontal bone loss, the crown must be removed and the intervention should be performed in a closed situation because it's impossible to rebuild coronary bone over the crest. When it's reasonable to extract a tooth and place an implant? In my opinion, there are two main situations. The first one, when a severe mobile tooth is losing progressive and uncontrolled bone loss in aggressive periodontal disease, we can extract it. Or we can extract a tooth, even if well treated, periodontally treated, when it prevents a more stable prosthetic solution, for example, a Toronto bridge. This is my opinion. If I have a tooth, a molar tooth, a maxillary tooth, with a severe distal angular bone defects, close to the apex of the tooth, today in a compliant patient with a good plaque control, and if the quality of the bone is quite good, probably at this moment I prefer to extract the tooth and to put an implant. The learning curve to obtain predictable results is a very long procedure, takes a lot of time, because I did many of these procedures, and I did many mistakes. And I realized that it is impossible to perform one of these techniques once for chains. If we do the procedure often, with paying attention, I think that in good hands, this is a very good surgical approach.